out on DST. But the problems with LPA are that it does not necessarily eliminate the need for culture in DST. You still have to do cultures for smear negatives. You still have to do a drug susceptibility testing for ethambutol, pyrazinamide, ethionamide, PAS, etc. And what do you do when MTB is not detected? And what do you do when you get an absence of a wild type or mutant? Is it really resistant? And what do you do when you get mixed infections? In 2010, the WHO endorsed NAAT, that is nucleic acid amplification test with a gene expert with a turnaround time of 90 minutes and had a sensitivity gain of 40% compared to the ZN. And there you go. The expert MTB RIF has a 75% sensitivity in kids, 82% sensitivity in HIV positive, 90% in others, and 70% in smear negative. So a clear advancement. And this integration of technology has been really a fantastic development for at least the laboratories, because it was basically molecular beacons with real-time PCR, fluorometric probes, sonic bacterial lysis. To me, the best thing about the expert has been its controls. It has a probe check control, it has a specimen processing control, and that will help each one of us not to compromise on quality control when we cope and struggle with these molecular tests that are so expensive. These are all inbuilt in the assay, and that really helps. And this was the NEJM publication that came out in 2010 that actually showed that smear negative and culture positive TB had, from one sample, had a 72% sensitivity. And we were part of this study, and this was in Mumbai. So it's real, it's happening, it's not just all over the world, it's even with us. So how does a test actually tell you the MTB RIF interpret the results? And as you as you get into experts, read it carefully and understand the technology, because when they say MTB is detected, they will tell you a low or high threshold. They will tell you that it's MTB detected when 2 probes are detected within this CT valid range. They would say RIF resistance is not detected or detected, and if it's indeterminate. And this is that same region that the LPA uses. It's the RPO beta region, which is from 507 to 533. And look at these colorful 5 probes. These are the probes that are the molecular probes, probe A, B, C, D, E. And if any of you have done this or used this assay, please go back and understand the assay, because at each probe, you can tell the clinician what is the level of resistance that your patient is having. The MTB RIF correctly identified RIF resistance. And in this recent Cochrane that was published in Jan this year, they showed that compared to culture, the expert MTB RIF detected 88% of TB with a specificity of 99%. This is overall, and if it was smear positive, it went to 98%. And used as an initial test, if you didn't even do phenotypic DST, expert detected 95% of RIF resistance with a specificity of 98%. It can pick up 131 copies of mycobacteria. And if you look at this chart, it would show you that a culture would require 10 bacilli, which it requires 50 to 131, but the lower limit is 50. Line probe assays require about 10,000 mycobacteria per mil, as would be a fluorescent microscope, and of course Capilla is done only from culture. We actually looked at expert MTB for extrapulmonary tuberculosis, and we found, yes, it did pretty well for biopsies, pus, and body fluids. And this was again borne out in the recent systematic review of expert for extrapulmonary tuberculosis, where everything does well with a sensitivity of around 84, 83%. But please, please, please don't accept expert for pleural fluid, because the WHO has actually said it's not a great test to perform for pleural fluids. Now this slide is really important because it would tell you the positive predictive value for detection of RIF resistance. Remember, when we push out a RIF resistant, it means this patient is MDR. It's a surrogate marker for MDR TB, but we're putting a patient on 2 years of treatment. We're giving him 120 injections. So we have to be dashed responsible when we push out this test. So if the prevalence of resistance in an area is 20%, and a review that was published in the ERS showed that in patients on a surveillance, patients who had been previously treated would have a weighted proportion of MDR of about 20%. So straight away, if you've had TB in the past, your chances of being MDR in the second time would be 20%, whereas if you've never had TB in the past, it would be 3%. Now let's look at, if you have had TB in the past, that is 20% chance of you being MDR in a subsequent infection, your positive predictive value for RIF resistance is 92%. That's not bad. And in which is why in low prevalence areas, if you get RIF resistance, if it was 3%, that's just 60%. So you need to confirm in low prevalence areas rifampicin resistance by either another molecular test or a phenotypic test. And the WHO in its wisdom has actually endorsed the gene expert to be used as an initial diagnostic test in MDR TB suspects. So you have to make sure that your patient is an MDR TB suspect or suffering from HIV TB. It can be used as an add-on test to smear microscopy in low MDR TB areas or in HIV prevalent settings. I don't know whether this is ready for you all yet, but this shows that this actually casts aspersions on the gold standard, that is culture DST, because they actually found that the non-canonical mutations, I showed you, remember those disputed mutations? That were identified in more than 10% of cases actually correlated with a poor outcome. Meaning that, friends, today we're moving more and more into the molecular era, and we're going to have to know everything there is about every mutation. I mean, you look at the physicians, the HIV physicians, they know everything about every mutation in HIV. We have to get there with TB now. And let's take this case. This was a case of a 32-year-old girl. She happened to be a minister's son. So you can, a minister's daughter. So you can imagine the pressure. A lymph node, she had this lymph node on the neck. She had a cold abscess, which was smear positive, and she was on first drug AKT culture negative. She had good adherence, and yet 3 months later, she reports this. And the treating physician is under a lot of pressure. This is drug resistant. Oh, you guys, this is Bombay. She has definitely drug resistant. This was aspirated. The smear continued to be positive, and cultures were awaited. In the olden world, believe me, she would have been put 100% on second-line treatment because no one wants to take a chance. Not only she's a minister's son, a minister's daughter, there's a lot of pressure here. We did the MTB expert, and we found that yes, she did have TB, but RIF resistance was not detected. So we could prevent 2 years of unnecessary second-line drug when the cultures are going to be no growth. Naturally, it's going to be no growth because RIF is sensitive. So you can use it to your advantage in such cases, and this was clearly just an iris or a paradoxical response which appears at least a month after treatment, especially in extrapulmonary TB. So if I were to sort of list and compare these tests, midget DST with Hain or expert, you can see that midget, that is culture DST, has a great sensitivity, can be done for XDR TB, takes a long time, can be done to all drugs, but it requires trained staff. Believe me when I tell you trained staff. Specialized infrastructure, cross-contamination issues, it cannot be point of care. The LPA can do most of these in 2 days and can pick up second-line injectables as well as the fluoroquinolones, but again it requires trained staff, specialized infrastructure, and there are cross-contamination issues. The expert MTB RIF can be done in less than 2 hours, but unfortunately, as of now, it only can be extended to rifampicin. I know there is the expert that is being extended for other drugs, but it's at least 6 months away. The good part of expert MTB RIF is that it doesn't need trained staff, and it doesn't need specialized infrastructure. So this is the diagnostic algorithm that we, from a high prevalence setting, would do at Hindujam. From a patient, the first thing that we would ask would be a smear and culture. Midget culture would go on side by side, but a molecular test would be done depending on whether the patient was an MDR suspect or a contact of an MDR TB patient or an HIV positive. If the smear is positive, we would do an LPA or an expert, and if the smear is absent, we would just go for expert. If midget is positive and the patient doesn't have the wherewithal to actually do the molecular test, then we would then go for a DST for all the drugs, etc. And if it was really urgent, not doing well by the time midget came positive, we may then go on to an expert directly from the culture. I'm going to spend the next 2 minutes on something that again is not WHO approved, but really fantastic technology that we believe is the future. Pyrosequencing and whole genome sequencing. Today we are in a position, at least in our hospital, to detect XDR TB in 6 hours. So we keep joking and saying, we have the technology, now what happens?